Support for the Health Channel podcast comes from Florida Cancer Specialists. Florida Cancer Specialists urges everyone not to postpone recommended screenings such as mammograms, colonoscopies, or biopsies. Regular screenings save lives. More at flcancer.com/getscreened.
Welcome to the Health Channel, All Health All the Time. I'm Olga Villaverde coming to you from the Baptist Health South Florida studios. Brain tumors may not be as common as other cancers, but they can be one of the hardest to diagnose and also the hardest to deal with. These tumors can affect how you think, how you feel. It can even affect brain function. That's why we use things like speech, for example, balance or coordination. Now, the good news here is that new technologies have given both patients and surgeons better tools to remove these tumors. And joining us today to discuss some of these new advancements in brain surgery is Dr. Vitaly Siomin, the medical director of the Brain Tumor Program at the Miami Cancer Institute. Welcome, doctor.
Thank you very much. It's an honor to be here on the program. Thank you.
An honor to have you. I don't think we've talked much about tumors on this show, so I'm really glad you had the time to spend with us today. Really appreciate it, doctor.
Thank you.
First of all, tell us a little bit about you and what you do and your passion for neurosurgery. We were talking a little bit about it, but I know you have that passion.
I'm one of the neurosurgeons at Baptist Hospital of Miami, and my passion is in brain tumors. It's something that I developed very early in my career. I think it's a fascinating topic. What attracts me in this area is a very strong bond between the patients, because we deal with life and death issues.
Sure.
Diagnosis of brain tumor is a very tough diagnosis.
It's a scary one.
I agree.
You hear that and you wonder, where is this going?
Yeah. Technically, these are very challenging cases, and oftentimes we have to deal with very complex anatomy, working in a very eloquent brain, and technological advances are incredible. So we have a lot of advances in this field, and altogether that makes it a very attractive field for a neurosurgeon.
I'm assuming you bond so much with the patients and their families because of this journey that you all have to go through, which is touch and go, if you will.
Agreed. Yeah.
Now, tell me a little bit about the tumor program, the brain tumor program at MCI.
It's a very large and comprehensive program, so we have a variety of specialists involved. I myself am a neurosurgeon, but it's not just about surgery.
Sure.
So you have to bring the oncology expertise. We have radiology expertise. Someone has to read the images and come up with a diagnosis. We have superb pathology department. We have oncologists who deal with chemotherapy and radiation therapy.
A huge team.
It's a huge team. You can visit our tumor board and you will see probably 50 different people, from physicians to rehab and other services, and this is when we discuss our patients' care. So that would give you an impression of how complex it might be.
I've actually seen it. It's almost like a brain tumor convention, if you will, of all these people coming together to try to make that perfect diagnosis for the patient. Right?
Correct. Yeah.
All right. So today we're talking about tumors in the brain. Doctor, we know that tumors can either be malignant or benign. Obviously, malignant meaning cancerous, benign meaning non-cancerous, which would be obviously the best scenario for a patient. Talk to me about the prevalence of brain tumors.
Well, the brain tumors, as drastic as they may seem, they don't really happen very commonly. So I can tell you that, for instance, patients get diagnosed with malignant brain tumor in the United States. That you would probably see maybe 65 cases out of 1 million.
Oh, that's
nowadays.
Small.
It used to be a little bit more common in the 90s, maybe 70, 75 cases out of 1 million. So it would not be a very common scenario. But then you may talk about also the autopsy series. Somebody
dies
and have an autopsy, and we would very commonly see benign tumors
really?
that are completely asymptomatic, meaning that they do not cause any problems or symptoms, and that's a much more common prevalence.
So that's the more common one.
Yeah.
Brain tumors, I've heard, can be described as primary or secondary. Can you explain that to us?
Primary brain tumors are the tumors that develop in the brain primarily out of the brain tissue or coverings of the brain. The secondary brain tumors, they develop elsewhere and they migrate and invade the brain. So that's the distinction. In other words, the secondary brain tumors are also called metastases because they metastasize from other places to the brain.
Which we hear of that when we talk about like breast cancer and things of that nature.
Correct.
So they spread.
Correct.
Okay. Now, according to the National Brain Tumor Society, the most prevalent brain tumor types in adults are, and if I say this incorrectly, doctor, please correct me, meningiomas and gliomas.
That's absolutely correct.
Okay.
Yeah.
What is the difference between those two, meningiomas and gliomas?
Meningiomas are more common. Meningiomas are about 30% of primary brain tumors. And these are typically, well, at least 80% of them are very benign, and many of them would grow slowly at a rate of maybe 1 or 2 millimeters per year. Very rarely they are malignant or more aggressive. Gliomas are different. Gliomas are the tumors that originate primarily within the brain tissue. They tend to be more aggressive, and it's much more difficult to cure them. And the majority of gliomas are glioblastomas, about 60–65% of them. These tumors are probably some of the most malignant brain tumors. They invariably recur.
Is this what the late Senator John McCain had?
Correct.
He did. Can you describe a little bit of his condition? And obviously now he's resting in peace, served this country for so many years. Just an honor to have him in our lives.
A brave man.
Very brave man.
He was diagnosed, to the best of my knowledge, with a tumor that's called glioblastoma. And they discovered it incidentally when he presented with bleeding behind his eye, and the surgeons did the resection of the tumor. Every time we take something out of the brain, we send it to pathology, and the pathology report unfortunately came back as compatible with glioblastoma. So he had his fight. I believe they resected as much as they could,
yes,
and they treated him with other treatments, and eventually he passed. But
so the prognosis for that one is really not very good?
Not a very favorable prognosis. Only about 5% of the patients survive 5 years. So the rest of the patients somehow lose the fight to their disease.
Correct me if I'm wrong, but I believe also former President Jimmy Carter had a tumor in his brain. Am I correct about that?
It's a different tumor.
It's a different one.
I believe it was melanoma. This is a secondary tumor that not a primary brain tumor.
And he was able to fight it.
Yeah.
Okay.
Yeah.
Risk factors, doctor. I'm wondering regarding brain tumors, is it family history? Could it be exposure to radiation? Do we know? Is it a fluke?
It's actually both. You're absolutely correct. Some of the tumors can be familial. About 5% of gliomas, for instance, run in the families, and it's typically secondary to some sort of genetic defect. For instance, TP53 mutation. It's one of the genes that controls the development of tumors in our immune response. If this gene is affected, patients can develop multiple tumors, including brain cancer. Other cases can be related to radiation exposures, and particularly meningiomas.
Okay.
Somebody gets exposed early in life, and then down the road may develop meningiomas 20, 30 years or so. There are cases that, again, that may be combined, but this is what we know can contribute to development of brain tumors.
Now, there's no doubt that there are challenges when treating brain tumors, so we want to show some of those challenges to our viewers and walk through them real quick, doctor. Blood-brain barrier, block therapies, what would that be?
Blood-brain barrier is it's a complex of tissues and cells that are form in the walls around the blood vessels. And the primary goal of blood-brain barrier is to protect the brain from all kinds of chemicals, abnormal electrolytes, metabolites that our body produces or has circulating within the body, so that they would not cross that barrier to affect the brain.
Okay, the next one is surgery, which is indispensable brain.
I'm not sure what they exactly mean, but in some cases, tumors can develop in areas that are very critical in behavior, in motor function, speech, vision, other eloquent regions, and that may limit the ability of surgeon to remove the tumor safely from this area. Sometimes we have to leave the tumor behind, and the tumor might need to be treated with some other treatment modality.
Okay.
Diversity. There are different types of tumors.
Of course.
Some tumors are very well circumscribed, and they can be safely removed and shelled out, from the capsule, and then the capsule can be safely removed. Other tumors are more diffuse. They grow just like trees grow with their roots into the soil, and it's very hard to remove every little rootlet. And tumor resistance is a different story. So some of the tumors can be very susceptible to chemotherapy and radiation therapy. Others are not sensitive at all.
A lot of people, before I take a break, are always worried about, their cell phones, and they say using your cell phone too much can cause brain cancer. Is that true, doctor?
Oh my goodness, we can talk about that forever.
That could be a whole hour show. Okay, so we're going to definitely bring you back, and we're going to talk about that. But it's just something that just popped into my mind right now. Brief answer? It's
a very controversial topic, and I'll just tell you that none of the agencies at this point in the United States support the idea that cell phones are harmful. But you got to be careful, because there was one warning by the WHO, it's a World Health Organization, in 2011, that there might be association between very heavy cell phone use, let's say over 30 minutes a day and even more, and brain cancer. But again, it's a very controversial topic, because there are different forms of radiation, non-ionizing and ionizing. So the radio frequency radiation that the cell phones emit and receive back from the cell towers is a non-ionizing radiation. So
all right, so let's ask you.
It just cannot, So
let's ask you a personal question. So, do you use the headphones when talking on the phone? Because if the neurosurgeon does it, I'm not going to worry.
I use both.
You use both?
Yeah, it's a kind of. I'm not obsessed about it. So let me put it like this.
All right, so not to worry. Thank goodness. Thank you for answering that. Before we take a break, I've always been marveled with specialties, and doctors, put so many years when they study medicine, but neurosurgeons. I'm just curious, doctor, how many years did you study to become a neurosurgeon? I'm going to guess 12.
Well, it's
considering residency, everything.
Yeah, well, in the medical school, I'm coming from Russia, so we would go straight to the medical school with 6 years. So, and then I started doing my residency in Russia. Then I moved to Israel, and I did 4 years of neurosurgical training there. It was primarily pediatric neurosurgery. And then we won green card in lottery, so we came to the United States. But in the United States, in order to be recognized as a specialty surgeon, you have to go through the same, through the residency over again. So that's what I did. I did my neurosurgical training at the Cleveland Clinic. It was 7 years, and that included 1 year of brain tumor fellowship.
We're up to 15 years now. I'm doing the math in my head.
Good, very good. I'm glad somebody's doing that.
Well, we are happy to have you here. Amazing.
Yeah, thank you very
Great
much.
to have you, and I'm so glad you came to this country, because I can see that you do a lot of great stuff for MCI.
Again, it's a privilege.
All right, so let's talk about how brain tumors affect the brain. Here are some of the symptoms patients may experience if they have a tumor, and the first one I saw was the headache. Now, doctor, obviously a lot of people get headaches, so it's not as if you have to think that you have a brain tumor immediately.
That's exactly right. And, I just really wanted to...
that's really important.
...focus, because so many people, probably everybody has a headache.
I just told you.
Yeah, and you just mentioned that during the break, so, I would really not worry about that too much, because the chances of a person to have a brain tumor when somebody presents with a headache is way less than 1%.
Okay.
It's 0.0001
so it's
something.
Really
so
less than 1.
It is really uncommon, and there are a variety of headaches that patients can present with. Most of the headaches are migraine types of headaches or tension headaches, and I would not scan these patients automatically. It's only when the headaches are very, particular, when they, affect patients early in the morning, associated with nausea, vomiting, they get progressively worse, or
Right.
when you see some other symptoms such as
like a balance problem,
like balance problems, seizures, other issues,
vision or hearing problems as well. All of those things coupled with that headache, but not just the headache.
No, not just the headache and not just the minor. Especially if it's somebody says, I've been having headaches for for many years and never had any other symptoms, then I would not scan that particular patient.
Okay, because you must get a lot of patients that come in and say, doctor, I have headaches, I suffer from headaches, and I'm really worried.
Not so much that they would reach the surgeon. So most of the headache patients would be handled by neurology.
Okay.
But occasionally we would have patients who would be maybe family members of brain tumor patients that start thinking, oh gosh, am I having
a
headache? Do I have a tumor? Is that
jokingly, we just said that during the break. I said, when I get headaches, I go, oh my gosh, do I have a tumor? And he laughed, saying, I hear that a lot. So no, you'd have to have other things like a balance problem, seizures, nausea, vomiting.
Or progressively worsening headaches would be concerning.
So when you have all of those symptoms that we just showed right now, then maybe there's a moment that you say, I need to get checked out?
Yeah. Well, gosh, if you have a seizure, you got to go to the
get
emergency room. So that's a different story.
Right.
But if it's just a headache, well, if you start having balance problems, something, go see a neurologist or maybe see a surgeon, and then you probably you'll need to be scanned
and hopefully rule it out.
Yeah.
What about personality changes? Can brain tumors affect your personality?
Absolutely, they absolutely can. Yeah.
How so?
Well, some of the tumors, especially that grow in the frontal lobes and cause compression of the frontal lobes, they can affect personality in people quite profoundly. People can become more stagnant. They're less interactive. They're not quite as sharp, and it takes them some time to do regular things and what we call activities of daily living. So everything becomes more challenging, and oftentimes these tumors are meningiomas, the tumors that we spoke about. They grow very slowly, and personality changes are very subtle. So they're not right away, right into your face, and oftentimes family members get used to seeing people the way they are, and they don't realize that the personality is actually different. Sometimes just somebody from outside would notice the difference and would bring it to their attention.
Because it's manifesting over a long period of time.
Yeah.
Interesting.
Well, oftentimes, if this is, let's say, if it's a malignant tumor that affects such as glioblastoma. So if it affects the frontal lobes, people can have profound personality changes, and sometimes it might be associated with speech problems with understanding, memory problems. So in those cases, we try to act quickly, and it's easier to diagnose if it's something that develops that acutely.
And speaking of diagnosis, diagnosis is a critical first step in recovery, of course, with anything when it comes to our bodies. I would imagine there are a lot of scans to help diagnose if there is a tumor, comprehensive images like state-of-the-art PET.
So, usually we don't start with a PET scan. So most patients would get a CAT scan, and as a screening tool, it would give you an idea if there's any brain shift, if there's any changes in the density of the brain to suggest that there's a tumor. CT scan is also very good to pick up blood and any of the acute changes that can be associated with brain tumors. Then, most patients would get an MRI, and the MRI shows the soft tissues. We can give contrast, and the tumors typically light up with contrast.
Okay.
And then we can see the borders of the tumor, the structures that they affect. And it's a much more of an anatomical image. So we could see the structures very carefully. We can see the blood vessels around them and draw conclusions. And then we can add functional MRI. Functional MRI would show you the function. It's based on the amount of oxygen that is metabolized and present in different tissues, depending on the function that this specific structure is involved at any given moment. So patients go through different paradigms. You would ask them to rhyme, count, sometimes sing, you know, talk, read back, and the MRI picks up the amount of oxygen in the tissues at that particular moment, so we can know that this is an aliquot tissue because it's involved in very active metabolism during that specific task. PET scan is more of a whole body type of scan, so we can see how metabolically active this tumor, how actively it extracts the glucose from the bloodstream, and that helps to determine aggressive tissue versus non-aggressive tissue, and also see the whole gestalt, the overall spread of the tumor throughout the body.
When you notice it, is it normally one tumor, or can you find more than one? Is that common?
Yes, we can find, you know, oftentimes we can find more tumors, especially if it's a tumor that is not a primary brain tumor but comes from elsewhere, let's say metastatic tumor. We can see at times multiple tumors, wow, sometimes as many as 20, 30, you know, etc. So in very bad situations, tumors can spread very dramatically and in multiple numbers.
And how do you determine, doctor, if it's cancerous or not cancerous?
It depends on the original histology of the tumor, and it depends also on the biological behavior. And we try to stay away from cancer in the brain per se, because sometimes benign tumor in the brain can be located in a very critical area of the brain, and it can be locally invasive. And the effects of growth of the tumor are maybe pretty profound, even though the tumor may be biologically benign, and if you look under the microscope, you don't see specific features that would indicate malignancy, but location really matters a lot.
So now let's talk about surgery techniques for brain tumors. The goal is obviously to get the entire tumor out if possible. And doctor, surgery usually is the only option?
No, it's not the only option.
But it's the best option?
It's one of the best options.
Okay.
And we always try to remove the buzzword here is as much as safely possible.
Okay. Makes sense.
We try, you know, when surgery involves, it's a major procedure, typically done under general anesthesia or awake. We would clip the hair a little bit or not clip the hair, depending on the patient's preference. We would make a skin incision, take a piece of bone out, expose the tumor, open up the membrane that covers the brain, and then we'd remove the tumor using microsurgical techniques with a microscope and micro instruments. And we also use different tools, such as ultrasonic aspirator that vibrates, shakes, and breaks the tissue and sucks it out. We use the bipolar cautery, we use different suction devices and different adjuncts to surgery.
All right. Do you decide what you're going to do after you go in, or is this something that you've already decided before?
It's pretty much pre-planned.
Okay.
So we kind of know what we're going to do.
Any surprises sometimes?
And if you just go and like start exploring, sometimes surgery, you know, turn out that good. I would say every surgeon should carefully plan.
Any surprises sometimes when you go in?
Absolutely.
Yeah.
Bleeding, you know, that maybe you may hit the blood vessel and, you know, nick the membrane incidentally, or you know, cause some spillage of the tumor cells, and then you have to somehow scramble and figure out how you're going to fix it. So absolutely.
All right, and depending on the type of surgery, depends on the characteristic of the tumor. Let's show our viewers what kind of characteristics there are that you have to think about in terms of deciding what kind of surgery you're going to perform, the type of tumor it is, doctor?
Well, obviously, if you're dealing with a benign tumor, they are much easier to remove because they are very limited to particular space, and the capsule is surrounding the tumor, so you can separate them from surrounding brain easier. With more malignant tumors, they are more diffuse and harder to remove. Size really matters because you know, you don't want to damage the brain. You don't use retraction. You try to remove the tumor piece by piece, whereas something that is smaller you can probably remove as a single block. The location really matters. You're very limited in a critical area of the brain, and as far as manipulation of the brain is concerned, you don't want to create any damage, and you can, you know, be a little bit easier with in tumors with that are located in less critical areas. Then we were talking about this pressure in the vital areas of the brain, so you don't want to use retractors, and we use what's called a dynamic type of retraction. So we cover the brain with little sliders and cottonoid patties and work by gently applying pressure to the covers so that we would not damage the brain.
And how long does the surgery usually last? I know everybody's different, doctor, but normally?
No, it really depends. It may be anywhere from 2-3 hours to, it takes about, you know, an hour to open and, you know, half an hour maybe to close, and and working on the tumor depending on the size and location and the critical structures around the tumor, so it may take, maybe a few hours. So some surgeries are very lengthy. They may just last hours, 10, 12 hours, easily. Sometimes if you do a spine case with, we would do a case, for instance, I recently did a 3-level vertebrectomy. So I removed 3 vertebral bodies from the front using the vascular surgeon for an approach. And then I came, we flipped the patient and did the posterior approach, working from the back when we finished removal of the vertebral bodies and stabilized it. So that was almost a 16-hour surgery.
Oh my goodness.
So it may take a while.
And the patient is fine?
Yeah. All things considered, some, you might be very sore. In recovery from anesthesia takes a while.
Obviously.
The lungs have to re-expand.
16 hours.
And you may have some collapse of the lung tissue that may need to come back to normal. So it takes some time. And then some of the patients need rehabilitation, physical therapy to recover from that type of surgery.
That's amazing. Another thing that I find to be amazing is this following story. Because did you know that sometimes patients may need to be awake for part of the surgery? Is this true?
That's absolutely correct.
Okay, I know you do this all the time, but for me, that was fascinating that you're doing brain surgery. I mean, you have a hole in her brain and she's talking to you for this mapping. That's amazing.
Yeah, that's exactly how it goes.
And she's aware of it.
Yeah, patients are completely aware.
Oh my gosh.
It adds a layer of stress, obviously, because the patient is in a relatively tight space. Oftentimes we put a head clamp on the skull to attach the antenna so that we could use that for image guidance, so that we could go precisely to where the tumor is and minimize the opening. And they're limited in the way they can move their neck and head, and there's a bunch of examiners and neurologists and neurophysiology team, anesthesia. People come and go, and we ask them to perform certain tasks. Some patients freak out, and in some cases, I had a 16-year-old who was undergoing that type of surgery. She was trying to grab my hand to stop me from doing that.
No.
I had a patient who was a very brave man, and he started to get some leg weakness, and the tumor was located very close to the area that was controlling the motor function of the leg. And that patient was a police officer, and he said, "I command you to keep going. I want you to take this sucker out." And we kept going. He ended up with some deficit, but he recovered very well in the end with some very mild residual. He was hiking in Cambodia, and I saw him at that grocery store quite often, for several years after surgery.
I command you.
I command you. That's exactly
How did
what he
you
said.
just maintain your composure? That's funny.
It's funny. It's actually. No, it actually releases the stress.
It does.
Because, when somebody talks to you like this, it's just like, oh, good, so we're not like about strict medicine and just, very formal, relationship here. You sign this consent, 50 pages of that,
That's so cute.
It's just like, it's very human. It's very...
Are there moments where you have to calm down the patient, where there gets a little bit hysteria?
Absolutely.
Okay.
Absolutely.
That's a little bit more
anesthesia
difficult.
plays a very key role in that process. Sometimes we start talking to them, and sometimes we just give them the phone, just like you saw on that video. So we give them the phone and ask them to talk to the family, and that might be soothing. They just can interact. They say, "Look, I'm doing okay. Everything's good." It puts the family at rest.
That's great.
And it's a great tool.
That's fantastic. Yeah. Oh my goodness. All right. So let's talk about some new advancements when it comes to brain surgery. Fluorescent dye. How does that work, doctor?
We inject fluorescein, or we're in a process of acquiring this 5-ALA technology. So this is something that the patient would drink, and then it would convert in malignant cells. It would convert into fluorescent porphyrins that we could see with a microscope through the blue filter. The dye is picked up by the tumor, and the tumor becomes very distinct from surrounding normal tissues of the brain, and we can guide our resection by removal of the fluorescing part of the fluorescent tissue only. So that improves the accuracy, and especially when you're dealing with eloquent regions of the brain. So it improves the extent of resection, which matters in the prognosis and survival of the patients.
Great stuff. Really great having you here today. Really.
Thank you.
It's such an honor.
It is my pleasure.
I'm very tickled you're here today. Really. There's a therapy called laser interstitial thermal therapy, or LITT. Tell us a little bit about this procedure, doctor.
We basically cook the tumor.
You cook it?
So we cook it, yeah.
Okay.
We take a laser probe and insert it into the brain, into the tumor, through a small burr hole. It is not a craniotomy type of procedure when we create a large incision and take a large piece of bone out. So this is sort of a minimally invasive approach. Then the laser probe goes all the way into the tumor, and then the patient is transported to the MRI. We have an intraoperative MRI here at Baptist, so we don't really have to physically move the patient. The machine kind of comes over the patient.
Okay.
And then we run special protocol that can detect the spread of the heat through the tumor. Where we can detect the spread of the heat.
Okay. And with that heat, what are you doing?
We just kill the tumor. Yeah, we elevate the temperature of the tumor to, higher than 40 degrees, 57 degrees, depending on the specific protocol that you run.
Wow.
And that's beyond the survivability threshold. So the tumor cells essentially die from just that heat exposure.
And who are candidates for this, doctor?
We use that primarily in patients with radiation necrosis. This is when patients get radiated for metastases and other types of tumor, and then radiation necrosis starts causing very significant inflammatory reaction in the brain, and patients can swell up, and that's one group of the patients. We can use it in some primary brain tumors that are very deeply located and hard to reach, and surgery would be otherwise very morbid. We could use it in primary metastatic brain lesions and other indications.
I think it's another procedure, an endoscopy?
Typically, they're rigid scopes. We would use image guidance to direct our path through the brain into the fluid sacs of the brain, and then the endoscope is used to perform the procedure, for instance, that is called endoscopic third ventriculostomy. So this is when we punch a hole in the floor of the third ventricle to interconnect the fluid sacs when the normal pathways are blocked by the tumor. Another area is skull-based surgery. So we operate on skull-based patients with my ENT partner, Dr. Pernis, here at Baptist, and we perform resection of pituitary adenomas, some anterior skull-based tumors, meningiomas, and metastatic lesions from the skull base through the nose, through the natural passages. And this is also a fascinating area, very minimally invasive approach, and great visualization, and it also requires a collaboration of a team. So I like the surgeries very much.
I know we've come a long way, but your thoughts of the future, new technologies when it comes to neurosurgery, what you're looking forward to?
I think it's really a fascinating field. Well, I'll just give you an example. For instance, glioblastoma that you started talking about. Glioblastomas...
which is what Senator John McCain passed from.
Correct. And they are hard to cure because these tumors are not just what you see on the surface. So I'll give you an analogy. I heard it from one of the neuro-oncologists. So about 1% of the cells in glioblastomas are stem cells, like cancerous cells, and they would be equivalent to, for instance, queen bee. And they keep producing those working bees all the time. And what we do with our therapeutics, with chemotherapy, radiation therapy, and surgery, we just kill those working bees. And the queen bees stays outside of our reach. So for us, it would be fascinating to find the ways to kill that queen bee so that we could address it precisely. It would be like a targeted strike in the military. And there are some receptors that are very, very specific to those queen bees, and we could target them. That's, for instance, one of the areas of development.
Oh, that would be fantastic. We're nearing the end of the show. I did want to ask you a question that's always fascinated me, because I always tend to read a lot regarding medicine and science. And I read an article the other day that we use, this has nothing to do with brain tumors, but it has to do with the brain. And since I have a fabulous neurosurgeon here, 10% of our brain. Is that true, doctor? That's just amazing.
It is. It is. It's controversial, but it is. Yeah, we can use a lot more. And what you can see with aging, for instance, patients can remain very functional and have a substantial brain atrophy. And there was even a paper in the Nature journal some time ago. So it showed that, you know, a patient with it demonstrated a patient with very significant mathematical abilities with significant brain atrophy.
Can you imagine how much more we're capable of? I want you to know it's been such an honor having you. I mean, MCI is very lucky to have you as a part of their family. Thank you so much.
Thank you very much.
All right,
it's my
so
privilege.
when you make that fish next time, maybe you can invite us all from the Health Channel.
Absolutely. Yeah.
There you go.
Yeah.
And just for, you know, why not? Because I want to have fun on a Monday. I know you're from Russia, so can you just say thank you for joining the Health Channel, all health, all the time in Russian?
Oh my goodness.
Come on.
Let me just translate it well.
Hurry, we got like 15 seconds.
Большое спасибо за то, что вы смотрите наш канал. Здоровья каждый день.
Oh my gosh, high five. You're the best.
Good.
Thank you,
Good.
doctor.
All right. No problem.
I love it.
Okay.
Be sure to join us next time on Health Channel, All Health All the Time on South Florida PBS. Follow us on Facebook and Twitter at All Health TV, where you can get health tips from our experts and see what's coming up on the Health Channel. You can also visit our website, allhealthtv.com, where you can watch a live stream of the show. You can see previous videos of our shows, and you can even learn a little bit of Russian along the way. I'm Olga Villaverde. We'll see you next time. How do you say see you next time?
До следующей встречи.
There you go. Have a great day.